లింక్ పెట్టేసాను. యూట్యూబ్ ఆన్ చేస్తాను అంటున్నా. సార్ మాట్లాడారా? చేశాను సార్. స్టాఫ్ అందరూ ఏమంటారా?
Sir, don't talk. Sir, దయచేసి 1 hour webinar.
సార్ మేడం వాయిస్ వినిపిస్తుందా మేడం?
వినిపిస్తుంది సునీల్, వినిపిస్తుంది.
మేడం సార్ వచ్చారు మేడం.
సునీల్
మేడం సార్ వచ్చారు.
సార్ స్పీకర్ సార్. సార్ రఘు సార్ స్టార్ట్ చేయమంటారా?
మేడం మీరు మాట్లాడండి మేడం. మనసా మేడం.
ఓకే సార్, నాదేం 1 minute తర్వాత సార్ మాట్లాడతాను. స్టార్ట్ చేయమంటారా సార్? ఓకే. సార్ గుడ్ మార్నింగ్.
సార్ గుడ్ మార్నింగ్ సార్. సార్ గుడ్ మార్నింగ్ సార్.
Good morning. Good morning.
Good morning, sir.
Morning. Morning to all. Sorry. Madam.
Sir.
Please start.
Okay, sir. Good morning to all participants and organizers. I myself, E. Manasa, Assistant Professor, Department of Pharmacognosy in Sun Institute of Pharmaceutical Education and Research. On behalf of Sun Institute, welcome you all. Today's session, a national webinar on 21st century pharmacy practice by Dr. Mohanraj Ratnavelu sir garu. Now I request Dr. A. Dinakar Reddy sir, Chairman of Sun Institute of Pharmaceutical Education and Research, to address today's speaker, Dr. Mohanraj Ratnavelu sir. Sir, over to you, sir.
Thank you, Manasa. Good morning to all, and very good morning to Dr. Mohanraj Ratnavel sir. Sir, how are you, sir?
Fine, sir. Good, sir.
Thank
How are you, sir?
I'm fine.
Yeah.
And also very good morning to all my colleagues, Dr. Shekhar sir, and all my friends, professional friends. Very nice to see you, and I am very, very happy and proud on behalf of all my Sun family colleagues because we are starting the first online national webinar today. And at the same time, I express my sincere thanks and gratitude for accepting for the seminar as a resource person, Dr. Mohan Raj Ratnavel, sir. Thank you, sir. And
Thank you, sir.
I welcome all the participants who are participating in today's national webinar. And he really, Dr. Mohan Raj Ratnavel, sir, is a very right person to be as a resource person and a speaker for today's webinar, because he is a very intellectual person, and at the same time he is having very good knowledge, very good research he did in pharmacy practice. As you know very well by seeing the invitation, today's webinar topic is 21st century pharmacy practice. It is very essential to know about the pharmacy practice at present scenario, because the pharmacy profession has a lot to do in this present condition, present worldwide uh, worldwide scenario and this pandemic situation. So I request Dr. Mohan Raj Ratnavel, sir. He is a associate professor in Raipur, and he is the member. He's having the membership in so many associations. He's having very good contribution. He's a young scientist, to be frank, in pharmacy practice. He's having very good notable contribution in pharmacy practice arena. So now I request Dr. Mohan Raj Ratnavel, sir, to give valuable note on this today's topic as 21st century pharmacy practice. Thank you. Thanks all. I request sir to continue. Thank you. Over to Ratnavel, sir.
Yeah, very good morning, all.
Morning.
Firstly, I thank the management of Sun Institute of Pharmaceutical Education and Research for giving me an opportunity in sharing my views regarding pharmacy practice. And I'm in the profession of teaching for the past 8 years, particularly in the core area of clinical pharmacy. And before that, I was working as a manager in an R&D company, LVP Manufacturing in Chennai for 2.5 years. So my exposure, whatever I have gained, I want to share those things with the young community, students, and the budding faculties in the pharmacy practice. And my sincere thanks to one of my student who is currently associated with Cyper, Dr. Murli also, for inviting me as a speaker in this particular occasion. And so with your permission, I could share my screen on the presentation. May I?
Okay.
Yes, sir, please.
Thank you, sir. So what today I'm going to discuss regarding the pharmacy practice in 21st century, the transformational changes ahead. So this is a topic I have taken for today's presentation. So without consuming more of your time, I move on to my slides. So over the past few decades, if you see, there is a very dramatical and a very higher contributory changes happening in the pharmaceutical market, particularly in R&D sector, and also in the industries, which have lead to discovery of many number of medications for the past 4 decades. And we have to really appreciate all these innovations and which have brought very tremendous changes in terms of pharmacotherapy, and most of the drugs really innovatively delivered were cost-effective medications. So apart from this appreciation on the real innovation, there are also considerable challenges regarding two aspects. One is the quality and rational use of drug. So whatever the drugs are available in the market are of assured quality, yes or no? Whether the assured quality medications are really available and they are being prescribed rationally or not. That is the very next thing we have to market. So as per the World Health Organization, if at all you take the scenario of pharmaceutical industry and the marketing aspect, uh, they are relying upon three important aspects. Number one is whether all the access of medications are delivered towards patient. Number two, whether the access medication were of good affordability. Number three, whether those affordable medications are being rationally used. So these are all the three eventful challenges dramatically and developing country are facing. So if at all you take the challenges, particularly in developing and industrialized country like India, providing an healthcare itself is a very biggest changes. And not alone the healthcare, it also involve a very important issues on pharmacy practice. So those challenges are due to certain reasons. Number one is rising cost of healthcare. Number two, limited financial resources. Number three, shortage of human resources in healthcare sector. Number four, inefficient functioning of health system. And five, huge burden of diseases. And out of it, the very important criteria will be a very changing social, technological, economic, and political environment, which most of the developed country are also facing. And due to this type of disastrous conditions, whatever the factor we have discussed, that is 6 factors, these factors are leading to a very major question mark in the arena of healthcare delivery, particularly towards a drug therapy. And if at all you get into the major constraint of drug therapy or medication use, number one is whether all and every individual or the public have a very good access to medication. Means it is a very bigger question mark. Why? Because recent publication of World Health Organization, they have given a statement clearly that 1/3 of world population are not having a very clear access towards the medications which are considered as essential medicines. And number two big challenge here is whether those medications which are available in the market are being rationally utilized or not. That is a major next outbreak which is happening in pharmaceutical field. For example, 2/3 of the population across the globe, they are spending nearly 60% of their annual income towards healthcare. So 2/3 of population spending 60% of the monetary on the healthcare need means those healthcare needs are rational. Whether they are optimized to an individual means it is a very larger, bigger question mark. And number three, whether a patient having an access and whether they do have an affordability means a recent scenario, I can say you, published by FIP, International Pharmaceutical Federation. They have told that 40% of the individual patients are not able to afford the medication either due to health constraint, majorly it is due to economical constraint. For example, in developing countries, we do have no better or good insurance claims over healthcare facilities. based on which we are spending a lot of money from our pocket, not being insured by the government or any type of national health mission. So these expenditures are fruitful towards healthcare means it is not so. Why? Because if at all you take the rationality of prescription in developing country, most of the patients are not being prescribed medications which are rational. Maybe the drug is very good in the patient, but it is not for the illness. Or else the drug may be indicated for the illness, but it may not be rational. These are all the challenges which are being faced at the current era of pharmaceutical field. For example, there is another more important aspect we have to concentrate is on one of a very global pharmacotherapeutic threat, which we define it as antimicrobial resistance, which have become a very biggest threat globally, where we are not able to define the humanistic outcome, not able to define the clinical outcome, and the monetary or the economic outcome are being not at all slaved to the half of the patient need. So what? This particular antimicrobial threat was being published by World Health Organization, and the publication was done in the year of 2002. And basically, this publication was from developing country, and they have given a statement that 90% of first line choice of treating shigellosis was a drug, ampicillin and cotrimoxazole, but it have developed into resistance. And for treating bacterial meningitis or pneumonia, penicillin is a first line choice, but in developing country, 70% of the people have been developed the resistance. And for treating gonorrhea, broadly, we are using penicillin in developing country, where 98% of people have developed the resistance. Apart from that, most often patient goes to the hospital for another treatment or ailment of illness, where they also acquire infection, which we call it as hospital acquired infection, or clinically we term it as nosocomial infection, for which we will be using cephalosporin or penicillin in developing country, but nearly 70% of the people who are getting treated for nosocomial infection are having resistance toward penicillin and cephalosporin. So if this is a current situation regarding the utilization of drug across the globe, particularly in developing country and industrialized country like India, the government functionalities has to work a lot on rationality, and they have to collaborate with most amount of organization whose main objective is rational delivery of healthcare. For example, I come up with certain policy perspective taken by World Health Organization. So number one is one of a statement which was been given by FIP, abbreviated as International Pharmaceutical Federation, and they have collaborated with IFPMA, International Federation for Pharmaceutical Manufacturing Association, in the year of 2000, and they have developed a policy called ensuring the quality and the safety of medicinal product to protect the patient. And this particular statement was developed by World Health Organization with a very common goal or objective to deliver the medications in a very appropriate way, indicated for the illness, and it has been individualized in the particular patient, and the drug therapy is optimized in such a way it is not going to develop any type of harm in the particular patient. And that was one of the policy developed by World Health Organization, and also in collaboration with FIP and IFPMA. So this is one of the statement on rational drug use. And another statement we can get onto it will be regarding antimicrobials, for which FIP have commands a statement called as Statement Policy on Control of Resistance to Antimicrobial. And this was developed by International Pharmaceutical Federation in the year of 2000 to make sure that the recommendation given by the FIP towards the government and the National Health Mission are running in a very good way, and they are delivering good prescription of antimicrobials or antibiotic within the public, and they are playing a vital role in limiting the resistance towards antibiotic. If this has been not framed, the current era of antibiotic delivery and the discovery will be on a bigger chaos will be created. So it was one of the finest role played by International Pharmaceutical Federation in the year of 2000. So particularly, all the organization or healthcare delivery bodies are playing a significant role in framing the policies. But whether these policies are being practiced well, either in developed country scenario or developing healthcare system like India or underdeveloped country, or as per our WTO classification of countries low economic country, middle economic country, or high income country. If at all you take this into consideration, we can say that policies are policies on a paper, particularly in developing country, but they have been not efficiently practiced in developing country due to inefficient healthcare system, or it may be due to a very reduced presence of human resources. And if at all the human resources are there, whether those human resources are highly qualified or not, that is a main problem in developing country. Maybe particular which defines a profession may be of high standard, but the practice during the curriculum may be a bigger lacuna in developing countries. And this lacuna requires an paradigm shift. So this shift is concentrated particularly on clinical therapy or clinical decision making with the presence of drug therapy. So healthcare professional team requires a person who are called as drug experts. And those drug experts are called pharmacy professions. And we have to be proud that in developing country scenario 2, after the introduction of this program PharmD in the year of 2008, most setting of healthcare are able to employ our PharmD graduate as a clinical pharmacist, and most often most of the PharmD graduate who are working as an academicians are able to deliver certain thing in relevance to patient care, and that shift has been occurred, but to the maximum standard it has been not achieved, for which we require a wholehearted contribution and a very collaborative work. So if at all you consider the profession of pharmacy literally from the history books of the pharmacy, primarily pharmacy profession evolved from a state called as compounder, and next to a dispenser, and now currently pharmacists are called as patient care provider. And this patient care provider, you have to consider this particular profession or the practice is also existing in developing country, but it is at its infancy. So it may take a decade to improve the profession of pharmacy as a patient care provider. So if at all you take the hierarchy of pharmacy profession, our original focus was dispensing and compounding of a medication, which have now been changed into an inclusive focus called as patient care provider, where the pharmacist plays a vital task in assuring the drug therapy and making the drug therapy giving an outcome which is having more benefit and lesser toxicity or no adversities. And this type of role played by the pharmacist will be called as drug therapy manager. And this approach is being defined as pharmaceutical care. So if at all you take a pharmaceutical care, it is one of evolving profession to be taken care of by the pharmacist, regardless to their practice. If at all they may be an academician, they may be a researcher, they may be a compounder or a dispenser. Our main objective is patient care, and our another important objective is delivering the need to a patient which is completely rational. So it was Epler and Spand who came up with the definition of pharmaceutical care in the year of 1990, and the definition was adopted by FIP, and they have amended the definition, and they have given a new definition for pharmaceutical care in the year of 1998. So I've given both the definition here. So if at all you want the current standard definition of pharmaceutical care, it is defined as the responsible provision of drug therapy for the purpose of achieving definite outcome that improves and maintain patient's quality of life. It means in the healthcare team, pharmacists are being given a platform where our role is completely subjected to drug therapy, and we have to play a vital role in such a way that the drug therapy which is being delivered to a patient is having more benefit, and we are making the patient to experience a very limited harm or a toxicity, and that particular limited harm or the toxicity is not going to create any hospitalization in the patient. Thereby, we are able to treatment, we're able to manage the severity of illness in the patient. If these two are being done in a patient in regard to the drug therapy, the patient quality of life will be increased and enhanced. This was the definition given by International Pharmaceutical Federation in the year of 1998, and the concept was called as pharmaceutical care. But in developing country, if you take pharmaceutical care cannot happen in any type of a vacuum area. It has to occur in any type of healthcare setting, or it may be a community setting. And this setting, who are been practicing in this setting at the previous aspect, they were not having enough knowledge about pharmaceutical care, and whatever the practice they have done is really in contrast to the practice which is going to be delivered to a patient, and which is a need of a patient, where it is a right to ask about the medication from an healthcare professional. So currently, the curriculum of pharmacy practice is framed in such a way that this contrast appeal is being declined, and those graduating student, either at the degree level, that is the B pharmacy, or a post-graduation, or else in PharmD, are being taught and practiced regarding brief inspirational account on patient care activities by including subject relevant to therapeutics and clinical pharmacy. So we can see that in India, this particular approach, that is a pharmaceutical care, has been initiated, and it requires more input to be contributed by every graduate. Thereby, we are going to get our profession evolved, and we are going to be considered as a member of healthcare team, and also we are going to subject a good delivery of patient care, and also monetarily our life will be somewhat appreciable and independent. And for this, It was once again the WHO who have instilled a concept called as 7-star pharmacist in their statement called Good Pharmacy Education and Practices in collaboration with International Pharmaceutical Federation in the year of 2000. And they have defined the pharmaceutical care could be extended only by those professionals who are having this 7-star. The 7 stars are caregiver, communicator, decision maker, teacher, lifelong learner, leader, and the manager. And another task which is under consideration is whether the pharmacist can be involved in the profession of healthcare research. So what it is under a notification by WHO, and within a year or two, it will be coming as a status paper by WHO, and we will be also appreciated as a researcher in the field of healthcare professional when we are practicing the profession with these 7 stars, namely caregiver, communicator, decision maker, teacher, lifelong learner, leader, and drug therapy manager. So now if at all you ask me whether this evolving profession of pharmacy have any new dimension, means yes, from the 20th century, there's a rapid evolution taking place in the profession of pharmacy, and there are certain multifactorial dimension of pharmacy profession which can be categorized into pharmaceutical care, evidence-based medicine, meeting the patient demand or need, chronic medication care, and self-medication, clinical pharmacy, and quality assurance, and thereby the last one is pharmacovigilance. So these are the multifactorial dimension of profession of pharmacy. And for this, the young budding pharmacist or already graduate pharmacy professional be working on how best the 7-star concept can be instilled into their real practice. So one by one, the dimension which is multifactorial, we will discuss. So number one, I've told the first dimension which have evolved rapidly in developing country too is pharmaceutical care. So what we do in pharmaceutical care, the very thing we do is the provision or the platform given to us is completely focused on drug therapy. We have to make sure the drug therapy which is reaching the individual patient is completely optimized. If at all you ask me what is meant by optimization, we have to make sure the particular drug prescribed is indicated for the illness and it is selected appropriately for the illness, and the drug chosen with its dose is very effective, and the dose is going to give you good concentration, that is bioavailability. So we call it is efficacious, and it must be economic, and it causes no harm to the patient. And this is the thing we are going to concentrate on pharmaceutical care. And this appropriate, indicated, individualized, effective, efficacious, economic use of drug is called as rational drug use. So literally you might have heard like right drug, right dose, right route to right patient is called rational drug use. So that is a definition for a better understanding, but the very clear definition is utilization of drug which is appropriate, indicated, individualized, optimized, efficacious, effective, and economic. And this is a very prime responsibility to be done by the pharmacist, and that role will be called as pharmaceutical care. If this particular rationality is being added either by the pharmacist or good compliance is being achieved by the patient, the outcome of the therapy will be very perfect good, where they will be getting treated, they will be getting managed for their severity of illness, and their quality of life get improved a lot and lot, making them more stable and reduces further hospitalization, reduces adverse drug reaction happening in the patient due to the drug therapy. And this is a very main objective involved in pharmaceutical care. If this pharmaceutical care is being rationally followed, we can assure that service provided by the pharmacist is one of high quality and good standard. And now, if at all you ask how a pharmaceutical care can be initiated in your own hospital setting or in your own community setting, or whenever the students are involved in practice of the profession in the hospital, at the bedside of a patient, or at the outpatient dispensing chamber, or in the patient counseling, how far this pharmaceutical care can be systematically developed. For that, I've given the answer like this. So we have nearly 4 steps in this. And number 1 is whenever you are planning to provide a pharmaceutical care, in what type of setting, it is not alone the hospital or clinical setting, in any type of pharmacy practice setting, you can provide the pharmaceutical care. And this is a very important right of the patient to be acquired from the healthcare professional, particularly from the drug expert, and those drug experts will be the pharmacist. So now, whenever you want to develop a pharmaceutical care plan, make sure that you have selected a very appropriate patient, or else you have done an effective background work regarding to what patient provide. For this, number 1 is assess the need of the patient regarding the drug therapy or else a drug therapy problem. So, so now if at all you ask what is called assessment. For example, if at all a patient is nearly 50 years elder and the patient is suffering something relevant to pain and swelling in the ankle, the very thing is you have to go for choosing a non-steroidal anti-inflammatory drug. So this is known to everybody. Even nurse knows, a doctor knows, and you also know. But better it has to be known in detail by the pharmacy profession in choosing what type of non-steroidal anti-inflammatory drug to be chosen. For example, a very effective anti-inflammatory drug, if at all you want, either you can take aceclofenac or indomethacin, naproxen sodium, paracetamol. This is a grade on their potency and effectiveness. And the same vice versa, it is their toxicity. So what aceclofenac may have a more ADR toxicity in comparison to paracetamol. And aceclofenac may be well prescribed in the patient if it is 50 years old, but it is having toxicity to be developed, which may be very, very limited or minimized in paracetamol choice. So now, this is our requirement that everybody knows a non-steroidal anti-inflammatory drug has to be given for a condition for analgesic effect or else for a pain along with the swelling. But what may be the appropriate non-steroidal anti-inflammatory drug to be chosen is a role of the pharmacist. So now our very first step is you first make or ensure what is the need for you in the particular patient, either optimizing a drug therapy or individualizing a drug therapy, or reducing the adversity or toxicity already produced by the drug which have been prescribed by the physician or the prescriber. So that is your need to identify in the first step. And to limit the toxicity or to enhance the benefit aspect of the drug therapy, you develop a care plan. That is what drug, what dose, what formulation, what frequency, how long it has to be taken, and you have to give some patient advocacy initiative, that is counseling to the patient regarding when to take, when not to take, with what it has to be taken, with what it has not to be taken. If at all the patient have missed a dose, what is the advice you can provide to them? Like this, you develop a complete care plan regarding the drug specific needs of the patient. And after that, step 3 is you implement the care plan to the patient. And step 4 is identify or monitor the outcome of the care plan, review it on hourly basis. If at all the patient is on emergency admission, or else on every 24 hours if the patient is been hospitalized, not in ICU, or else the patient may be an ambulatory, that is outpatient, coming to your pharmacy to refill the prescription. You review the patient on every refill, and if at all you feel the outcome is achieved, the profession is well appreciated. If this care plan is not that much effective or the outcome is not achieved as per your desire, that is what you have planned or what the instructor, that is a prescriber, have planned, you can once again move forward to the step 1. So this complete step or schematic approaches can be well achieved or done by a pharmacist only when we have good expertise, knowledge, and skill in setting the priority of drug therapies. Clear? So the very next thing is, if at all you focus on how far this particular schematic steps can be achieved, means we have 4 rules which are called as pharmacy practice activity classification. Could be practiced in hospital setting, could be practiced in community setting, could be practiced anywhere we provide our resource or information towards the patient. And that was being given by American Pharmacist Association in the year of 2002. And that is being called as PPAC, Pharmacy Practice Activity Chart. And we have 4 effective roles in it. Number 1, ensuring the appropriateness, therapy, and its outcome. Number 2 is dispensing medication and devices. Number 3, health promotion and disease prevention. Number 4 is management of health system. So what in developing country, mostly we are focusing on all these 4, but we are not we are not able to find out the outcome, and we are not able to ensure a good documentation over it, and that is a lack in Indian pharmacy setting. And if you get into another dimension of pharmacy practice, which is a very highly appreciated in India, why? Because I can clearly justify, we in our hospital are being well appreciated. The students are well appreciated. Why? Because we are able to provide evidence-based medicine in pharmacy practice. It means I'm not saying more good about my college or my student, but it is my obligation to say in our institute, we have a drug information center and also the poison drug information center in the hospital, where students are working in this COVID pandemic too online, and we, the faculty members, are also working on it on everyday basis. And whatever infodemics, that is the information they require the healthcare professional or the public require regarding prevention strategies or management strategies of a COVID pandemic, we receive call from them and we are answering them. And all the information what we give are unbiased, well-referred, critically evaluated informations, and it has been regularly updated from the organizations of healthcare like WHO, FIP, Commonwealth Pharmacists Association, and American Pharmacists Association. And we are also having a very good database on drug information where we are able to retrieve a very updated information of COVID-19 pandemic too. And all of our department faculties are working hard on a daily basis. We are coming by 9 o'clock. We are leaving by 1:30 from the college. And I'm not saying once again good about my college, but this is a thing required by the public since it is a right or fundamental to get their need clearly educated regarding the disease and drug therapy, for which the healthcare professional team of our hospital is largely depending on us. So if this is being done in one of the rural healthcare setting in Andhra Pradesh, I think we can do a marvelous collaborative and integrated services to healthcare in all aspects of pharmacy institutions running all type of program for the benefit of the patient care. So if at all you ask what is evidence-based medicine, it's very simple. Whatever the informations which are being available up to date, we have immense informations. And those informations may deliver a fact, some falsified statement, some repetitive fact, and the fact may not be updated, or no recent researches might have been done on the fact. So the very important role is the pharmacist has to work on providing informations with no falsification, and the falsification informations may lead to more amount of adversities. And this particular evidence-based medicine, if at all you consider the role of pharmacists is very important. Why? Because for making a clinical decision or a pharmacotherapeutic decision, every individual prescriber has to read 19 journals to make a very effective decision for providing one patient care drug therapy, which is very, very harm for them. Harm in sense, it puts them into academic isolation, means they have to rely only on books for the complete day, and they may not have sufficient time to make the consultation with the patient, so they cannot treat oftenly the patient. So it puts them into an armchair. So if the prescriber is being put on armchair, the complete healthcare team or the delivery will also be in armchair. So the care what we provide will not be a definitive therapy, or the outcome is going to be nullified. So there may be more healthcare burden on the patient or individuals. And this particular evidence-based medicine is a very groundbreaking concept, or a very new concept, which was given by David Sackett in the year of 1996. So now currently David Sackett sir is not alive. He expired in the year of 2015. And Sackett came with a very good definition on evidence-based medicine. And that EBM is not only confined to medical field, it is been a spectrum into a broad, into pharmacy, nursing, and allied health profession also, where we are going to give decisions based on current best evidences to an individual patient. And those evidences, what we are going to provide is going to be judicious. So it will, judicious means there is no thing of a word called as alterations or faking of information. Number two, it is going to be consent-to-us, means the information specific to drug therapy or disease diagnostics, not for a group of patients, for individual patient. And explicit means those informations are retrieved with very high quality data informations. All right. For example, you want me to discuss on EBM and our role in EBM a lot. I have a case for you, which may take a few minutes. So I think you'll be interested on a case. So what I do is I have a patient who is a female and she is 73 years old, means she is elderly geriatric. She is very old and she have met with a fall, and during the fall, right hand wrist has been fractured. This is the case. And she got admitted into the hospital. After a few days of hospitalization, what happened? She was complaining lightheadedness, daytime drowsiness, poor short-term memory. And after her complaint, the physician and the team of healthcare have assessed her completely regarding her past medication history. Everything was been assessed, and the patient told that she is a patient of chronic illness of 4 years together before, and she was under the treatment for those chronic illness, and they are hypertension, cardiac failure, angina pectoris, osteoarthritis, iron deficiency anemia, and anxiety. So all the six are the illness which requires no lifestyle modification. It relies highly on drug therapies. So we asked her about her past medication. She was saying that she was taking nearly 9 medications for more than 5 years. And those drugs are digoxin, furosemide, potassium chloride, prazosin, metoprolol, naproxen sodium, diazepam, and iron supplement, and she was on aspirin. So now, if at all you take, as a pharmacist, what is our role? We have to make sure whether all the drugs are appropriate. So now if you consider, yes, all the 9 drugs at the initial level are appropriate. For example, digoxin is used in the treatment of cardiac failure. Furosemide is used for cardiac failure. Potassium chloride is used. Why? Because if at all the patient is on a furosemide, it leads to lower concentration of potassium level in the serum. So for its replacement, we are using potassium chloride. And for treating hypertension, we are using prazosin, an alpha blocker. And for treating angina pectoris, along with heart failure, we are using metoprolol. And for osteoarthritis, we are using naproxen sodium and diazepam for her anxiety, and iron supplement for her iron deficiency anemia, and aspirin as a thromboprophylaxis for cardiac illness. So now if you see all the 9 drugs, yes, they are having their indications. So now further the patient was assessed and she was having a very normal BMI. Why? Because she was 168 height in centimeter and her weight was 55 kilogram and her BMI was around about 21.8. So she's very normal on her body mass index. Her BP during admission, the blood pressure was 120/70. Her pulse rate was very normal, that is 70 beats per minute. And a blood test was ordered along with the electrolyte level. It showed sodium, potassium, and serum creatinine of renal function test was also normal. But you can find out the hemoglobin is 105 gram per liter. So if at all you convert that into SI unit, it comes around 10.5 gram per deciliter. But a normal range for a woman, the hemoglobin must be around 12 to 14.4 gram per deciliter. But she's not a woman, she's an elderly woman. So 10.5 gram per deciliter is also a choice of a good indication of hemoglobin. But for our satisfaction of abnormality, we have given an iron supplement to the patient. So now at the face value, if at all you consider, the drugs are appropriate. But if at all you check the individual patient, whether it has been optimized means, I think no. Why? Because the drug therapy is polypharmacy. So now you may ask, that was a prescription written by a doctor. How a pharmacist can interfere and give an intervention that it is a polypharmacy? Why? Because I have very good evidences over it. So what may be the evidences? Number one, as per BMC geriatric, I have a systematic literature suggesting what is called polypharmacy. So what is meant by polypharmacy? Number one, multiple use of medication or concurrent use of medication for a long period of time is defined as polypharmacy as per this systematic review. Number two, use of more than 2 drugs in the treatment of single illness is polypharmacy. Number three, use of more than 3 drugs in treating one illness or multiple illnesses in relevant to one particular organ is called polypharmacy. Or else, utilization of more than 5 drug of threshold for a long period of time is called polypharmacy. So now if you see our particular drug therapy, we have 9 drugs, so it is polypharmacy. The patient is taking 2 drugs more for the treatment of single illness, that is digoxin, furosemide. You can consider potassium chloride, or else you can take metoprolol. So more than 3 drugs for the treatment of single illness. Number third point is the patient is on more than 4 drugs in treatment of disease relevant to cardiovascular system, and the patient is on 9 drugs for a more chronic period. So clearly the prescription is polypharmacy. So now what I can do, as per one of a very clear report given by American College of Cardiology Foundation 2013 regarding treatment of heart failure, they said ACE inhibitors are superior than digoxin and furosemide. So now, particularly in geriatric, it was a report. So now there is a chance for us to replace digoxin and furosemide by giving a ramipril, that is an ACE inhibitor. And that particular ACE inhibitor also play a vital role in treating your hypertension of the patient. Number 3, the patient was being admitted with the right hand wrist fracture. Why? Because she have fallen to the ground. And the main reason we can consider here is her blood flow towards the brain may be lowered, and it may be called as hypotension. And if at all you see whether there are any drug in the prescription causing hypotension, means yes, I have 3 drugs, prazosin, metoprolol, and furosemide. These 3 drugs are having its effectiveness to cause orthostatic hypotension. So do I have any evidence on this? Yes, I have an evidence on it. And I've given your antihypertensive therapy in elderly, effect of blood pressure and cerebral blood flow, where they have suggested prazosin, an alpha-adrenergic blocker, is not indicated in the treatment of hypertension in geriatric or elderly patient. Why? Because it is one of the finest drugs having more incidence of causing reduced flow of blood to the cerebral area, causing orthostatic hypotension. In comparison, metoprolol and furosemide are not that much incident of causing orthostatic hypotension. So I have another point here of considering the replacement of prazosin. All right. Number 3, particularly in our prescription, we have diazepam, which is a long-acting benzodiazepine. And this long-acting benzodiazepine undergo an oxidative metabolism, and it leads to active metabolite. It is completely cleared by liver. So that particular drug may stay for nearly 220 hours for a long half-life. So the patient may suffer giddiness a lot, and the patient may be on sedation for a long period of time. Once she come out of the sedation, she will be having some poor memory. So these all three conditions have occurred in the patient. So the three complaint of the patient may be due to the exposure to diazepam. So what is the strategy I can use is I can replace a drug, benzodiazepine, diazepam with a short-acting benzodiazepam, the oxazepam or lorazepam or temazepam I can use in the patient. Why? Because they undergo conjugation reaction. It means they will not lead to any active metabolite. It means the drug is not going to be there in the serum for a long period of time. So it is not going to cause any complaint relevant to drowsiness or poor short-term memory. And then I have one more evidence that replacing naproxen with paracetamol. Why? Because naproxen in prescription may cause GI bleeding, may cause anemia or fluid retention, or it may have an antagonist property towards the antihypertensive like furosemide used in the prescription. So this, with all evidences, what I did is I have came into a plan of replacing 9 drugs into 6 drugs. So this is not polypharmacy. Why? Because I have no 2 drugs for treating a single illness. I don't have more than 3 drugs acting on single organ, and I have no multiple medication on concurrent use. So my final prescription for a patient was Ramipil 5 milligram, paracetamol 500 milligram, oxazepam every day at only night 2.5 milligram. Pecontin is one of an iron supplement with more amount of iron concentration. And metoprolol, a beta blocker for the treatment of both angina and heart failure. Aspirin for the thromboprophylaxis. And I make sure the information given was very rational, and that was well appreciated by the physician. And this is called evidence-based medicine in pharmacy practice. So the requirement of pharmacist role is very, very realistic in the particular case. It was evident, and the need of pharmacists in healthcare team is a very vital part in healthcare delivery, which has to be rational. The next dimension is meeting patient need. This is relevant to advocacy. Advocacy is nothing but counseling. So we are a center point of counseling things relevant to drug and disease. So we call as advocacy for drug and disease specific counseling, where we are going to give information of drug monitoring, disease monitoring, drug and disease management. So what we have to do in counseling is always we have to rely on informations which are factful, which are having no clinical terminologies, which are going to be very, very importantly understandable. And once for all, we have completed a counseling, we have to assure the understanding is correct. So you can develop your own counseling point with open-ended, close-ended, reflex questions, and thereby you can assess to what standard the information provided by you is fruitful in the particular patient. And number 2 is chronic patient care. So here chronic patient care, I have focused literally only into HIV and AIDS. Why? Because it was a very disastrous prevalence in developing country, particularly in China, followed by India. We are having a more number of cases in the mid of 1995 to 2000. But World Health Organization have really appreciated the workforce of pharmacists in the year of 1997 in combating the HIV, where the previous thing what I said is advocacy. So all the community pharmacists and the dispensing pharmacists and the hospital pharmacists, played a very vital role in Indian healthcare setting regarding creating awareness regarding HIV. Thereby, most of the public were aware about HIV, its transmission, its prevention, its treatment strategy, the significance of antiretroviral therapy. Thereby, pharmacists were one of the key component pillar in reducing the incidence of new happening cases of HIV and AIDS, acquired immunodeficiency syndrome. And that was been well appreciated by International Pharmaceutical Federation in the year 2003 in combating HIV, and they have given a statement on improvised role of pharmacists, and that came into enactment as a policy regarding particularly role of pharmacists on antiretroviral therapy outcome, where we played a vital role in enhancing the adherence of the patient who were on long-term treatment of HIV. If at all you want the proof, you can get into a website called fip.org, HIV AIDS. If at all you get into the website, you'll be having the research summary report of WHO in collaboration with FIP, and you can know to what extent the pharmacists in India particularly played a vital role in training, educating, and making the documents or during the disastrous arousal of 1990 to 1995 in the cases of HIV, thereby acting as a one of the combat pillar on HIV and AIDS in India. So the very dimension of the next is self-medication, where I can say you, not all the guidelines are saying pharmacists are the centric point. And yes, pharmacists are the centric point in delivery of optimum drug therapy, not alone in hospital. They also play a vital role in their dispensing chamber in the community pharmacy regarding self-medication, where there are certain drugs which could be taken out from the pharmacy without a prescription. So these drugs are being given to a patient with very clear information regarding its outcome. And this policy was given by FIP, and that was been well appreciated. And the statement was appended in FIP. If at all you want the statement, you can take from 1996 statement on principle of self-care medication, the role of pharmacists. The very next one is clinical pharmacy and quality assurance. So this is a very important thing for any type of individual who are going to enter into education to pursue their degree at pharmacy practice or practicing in hospital. Why? Because the main role of clinical pharmacist is not alone drug therapy outcome efficiently. Our another outcome is reducing toxicity or limiting the arousal of the risk or outweigh the risk and improve the outcome. Why? Because any drug, whenever being administered, will have both benefit and risk. So it is a potential role of the pharmacist to outweigh the risk of the patient, and we have to make the patient to experience all along the benefit of the drug therapy. And if at all you ask, what are all the clinical pharmacy services means? Management of drug-related problem, management of medication error, management of adverse drug reaction, improved quality of life, and reduction of length of stay of a patient in the hospital, and giving ambulatory services towards the patient for their outpatient care facilities. And if at all you take pharmacovigilance, that is one of a next dimension, more correlated with clinical pharmacy, where pharmacovigilance, as per the definition given by 2002, is a science and activity relating to the detection, assessment, understanding, and prevention of adverse effect of a drug, either on a short term or a long term. So This adverse reaction are further defined as a response to a drug which is noxious or unintended, which occurs at doses normally used in human for the treatment, prophylaxis, modification of physiological function given by WHO in the year of 1972. Why? Because 37 to 42% across the globe, the hospitalization is due to the adverse drug reaction of those drugs which have been already in use by the patient. And number two, 20 to 32% of economic burden is due to adverse drug reactions. And the role of pharmacists is very vital in this adverse drug reaction. Why? Because we are drug expert. We know the pharmacology, mechanism of action, the dose, dosage form. Most important is bioavailability, concentration, kinetic and dynamic outcomes, adversities, side effects, risk categories, precautionary measures of all the drug therapy and individual drug or category of drug. So we have to collaborate with the healthcare professionals in bringing the drug therapy very, very rational, and that rational drug therapy must be very cost effective. Thereby, we have played a role in reducing their healthcare burden too. And if at all get into the history of PV, I'm sure that everybody know that the World Health Organization have established this International Drug Monitoring Center in the year 1961 due to the thalidomide disaster resulting in phocomelia, that is untoward experience of the newborn baby with no limbs, either it may be upper limb or a lower limb, along with cerebral hydrocephalus, means the brain accumulation of fluid in the brain, leading to brain damages, dwarfism. Many things happened due to thalidomide. So to end up it, the World Health Organization started the International Drug Monitoring Center in the year of 1961. And now if you get the status paper of WHO in the report of 2010, we have 134 countries under PV program of WHO, which is called as Uppsala Monitoring Center. So I think these many significant role and multi-dimension exist in the pharmacy profession, but to the maximum, if we, the pharmacists, are highly qualified with the knowledges in respect to pharmacology, biopharmaceutics, hospital and clinical pharmacy, and pharmacotherapeutics, we can render and do wonders in patient care, and we will be very proud enough to be a part of healthcare team. And with this, and these are all the two guidelines you can depend on: medication error, that is NCC-MERP, National Coordinating Council for Medication Error Reporting and Prevention. And for drug-related problem, you can rely on PCNE, Pharmaceutical Care Network Europe. These two guidelines, if you read, you will understand what are all the differences between drug-related problem and medication error, how it could be limited, how they are classified. Everything are clear enough, but reading alone is not important. You have to put your knowledge into real practice. And sure, I feel that budding pharmacists with the effective knowledge of clinical pharmacy and therapeutic and biopharmaceutics particularly will come with greater rights. At the end, I'm very thankful to the management of my institute, Raipur, for relieving me from some work for today. And very, very thankful to the management and faculty members of CIPER for giving me an opportunity and sharing my views on the newer trend of healthcare system and the role of pharmacist. So I appreciate the effort taken by the faculty of pharmacy practice, CIPER, in bringing up the webinar. Why? Because if you give chances like this, we can collaborate, we can integrate, we can grow, we can succeed, and we can sustain the profession to a very global standard. And thank you for all your patience listening. And thanks for all the organization committee members. And thank you one and all. With this, I stop my presentation. So over to the admin or the host of the webinar.
Hello.
Yeah.
Hi, sir. I'm Shweta from Cyber College. I would like to appreciate for giving this seminar. I would
Yeah,
like to
thank you.
express my appreciation and gratitude for accepting our invitation in a national webinar on 21st century in pharmacy practice in Cyber Nellore. On behalf of our organizing committee, we thank for your fabulous participation and support that you have extended to our student participants and faculty
Yeah.
for making the webinar a success. In spite of your
Yes.
busy schedule, you have reported the national webinar within the short notice and made your effective presentation with commitment and dedication. We look forward to organize many
Yeah.
more seminars under your eminent guidance and dynamic leadership also. Thanking you
Yeah.
for giving the great presentation today, sir.
Thank you all. If any queries are there, you can put up,
Yes,
or
sir.
else we can move up.
Yes, sir. Yes, sir.
Virendra. It's not- it is. Any queries? Video.
No, sir. No queries.
Uh,
Hello?
yeah.
Yes, sir. No queries, sir.
Oh, fine. Good. I think they have understood some knowledge they've gained. So I
Yes, sir.
thank
Yes.
once again the chairman, principal, faculty members, and staff, non-faculty or technical team of CYPER, and giving me an opportunity to share my views. And thank you. Have a great time.
Thank
Thank
you
you.
very much, sir, for giving the presentation again, sir.
Oh, thank you. Good. I leave the meeting, right?
Yes, sir. Okay, sir.
Yeah.
Hello?
Madam.
Sir.
Okay, madam. Thank you very much.
Okay, sir. ఇంకెవరికి వినిపించదా ఓకే సార్
Okay, madam.
ఓకే సార్